First, a few acknowledgments. This work takes a village. It was not primarily done by myself. It was done mostly by Ashok Kumar, who was a graduate student in the lab of George Whitesides at Harvard. It was taken to Doctari Diagnostics. I'll talk a little bit more there, and had significant contributions with Bill Rodriguez and Marta Fernandez Suarez. We worked closely in a field trial with Catherine Chundaleoka and Hamankwa Mentina at University Teaching Hospital in Lusaka, Zambia. We've had significant medical help and sample provided by Dr. Carlo Brugnara and Dr. Julie Cantor-Washko, who I know lots of you here work with. The idea for the initial test actually came from Dr. Tom Stossel at Brigham and Women's Hospital, and we collaborate with Dr. Sergei Shevkoplias at University of Houston. And we've had, moving forward, significant help from a manufacturer called Drummond Scientific, and there Chris Stroessel and Rob Miller have been instrumental. Many people here have talked about the problem and significance, and I don't think I need to reiterate that, except to say that in places like Lusaka, Zambia, unlike India, they don't have the significant screening efforts there. So when we began our field trial in Lusaka, they didn't have a working electrophoresis or HPLC until we provided them one for our study. And so that presents a major challenge to any type of diagnostic in some of these areas. So our device is a different approach to the other people here in this room, in that we exploit the natural density difference between sickled red blood cells and normal red blood cells. We're now on our third generation device, which shows greater than 96% sensitivity and specificity under field use conditions. I also have to add that it's really impressive for me to see sort of the huge upswell in point of care tests that is shown here. And I'm really happy to share the stage with a lot of people who've developed a lot of different devices using different methods. The only thing I have to add to the diagnosis gap, besides what's been talked about today, something that was really interesting, Professor Italia said today that of the sickle screening done in Gujarat, they had 4.6 million solubility positive tests, and of those only 2.9 million tested positive for trait on second testing. So that's a 65% rate, and that shows that is a huge problem with just using solubility tests. Density is a potential marker for the diagnosis of sickle cell disease. So these plots show the density distribution of sickle cells with hemoglobin AA and SS, and I've highlighted these dense cells in red here in the density distribution. And you can see there's a relatively sharp cutoff here where only SS, and in the case also SC, and we found evidence for SO Arab as well. Importantly, sickle cell trait, AS, has a similar density distribution to AA. That means that any test that uses density to diagnose the disease cannot differentiate normal AA from trait. The system that we have used relies on a technology that was developed in the Whitesides lab called aqueous multiphase system, or AMPS. AMPS are mixtures of polymers and salts in water that spontaneously phase segregate to make discrete layers. So imagine like oil and water, except because the primary component is water, these things can be tuned to have very small differences in density, and they are also, very importantly, thermodynamically stable. So if shaken, like this image here, if left to sit over time or put in a centrifuge, they will automatically phase segregate to their discrete layers. And the image here shows a 5-phase system where there's 5 discrete layers. The basic principle of our test is loading a container of some sort, and I'll show you more pictures in the next few slides, with an aqueous multiphase system. So we have here a top phase and a bottom phase and a liquid-liquid interface. We load that with blood, and if we centrifuge the system, normal red blood cells are designed to pack at an interface, whereas dense sickled cells fall to the bottom of the tube, where they can be detected easily by eye. This is the design of our first generation prototype that we worked on at Harvard. You can see we use a microhematocrit tube, the same thing, the small plastic tubes that people use to measure hematocrit with. We've poked a hole in the top of it, which allows for blood to wick in. It also allows for a controlled metering of 5 microliters of blood. Then put a silicone sleeve around that, which can be pulled down in order to allow the blood to enter, and put back up so that upon centrifugation, blood does not come out the side. The results of a test are shown here with a negative sample. It is always difficult to see in pictures because these tests are so small, but this is a negative sample. There's no red at the bottom, and this here is a positive sample where there is a strong red signal at the bottom. So the components of our test, these are the tests that we shipped to Zambia. There are 12 packed in one container. We use a battery-operated centrifuge. This centrifuge here was the one we used in our initial studies in the lab. It's a $1,500 centrifuge. We've recently moved to a centrifuge that off the shelf costs $150, and you can buy them or make them for much cheaper, and we're working with our partner to do that. There is the test there. We store them in water to keep the osmotic pressure the same inside and outside of the tube. We fixed that problem moving forward. But you can see it simply relies on a finger prick. In this case, there's a cap that seals the liquid inside the tube. The sleeve has already been slid, exposing the hole so that blood can enter the device. Blood wicks up to the hole and no further. The sleeve is slid closed, and the device can be put into the centrifuge and spun for 10 minutes. This centrifuge operates at around 10,000 G. It requires only a car battery. You can spin at a slower speed depending on what centrifuge is available. It just takes more time, and conversely, a faster centrifuge would take less time. So the first prototype device, we use 2 different systems, those aqueous multi-phase systems, a 2-phase system and a 3-phase. The initial idea behind the 3-phase is there's actually a density distribution difference between SS and SC, and we were hoping to be able to differentiate those two. We have preliminary data that says it's possible, but we haven't had enough samples in order to correlate that appropriately. But in the best systems, our 2-phase systems, we find a sensitivity of 90% and a specificity of 97%. This is the second prototype that we took to the field trial in Zambia, where we performed a 505-patient case-controlled field trial at a university teaching hospital. We added a cap to our system to make it stable over time. We also added a seal at the bottom with glue in order to maintain packaging over time. When we went to Zambia and tested these on patients in the hospital, we found a significant decrease in the specificity of our system. So sensitivity still was okay of 87%, but the specificity dropped precipitously in the best system. We found 2 major causes to this. Thankfully, 2 of those causes are fixable. The first was the time from collection to use. Because of our IRB, we weren't testing these on a finger prick, we were testing them on venous blood samples, and we found a significant drop in performance the longer a sample was used in the test. So we allowed in the study up to 48 hours, and the samples that were tested within several hours had a much higher sensitivity and specificity than those tested near 48 hours. The second thing that we believe decreased performance was manufacturing and shipping. We didn't have tight enough quality control in the system that we sent out, and we realized that there was large batch-to-batch variation. So the best batches recapitulated the results from Harvard's study, but the worst batches brought down the bunch. Sort of an additional challenge that happens when you do these field trials that many of you, I'm sure, have experienced yourself, is that we found when we sent one of our batches to Zambia, it got stuck in the tarmac in Nairobi, Kenya when the airport burned down. So it was sitting there for over 2 weeks, presumably in hot conditions, but we didn't include temperature loggers with the devices, and therefore we couldn't throw out the data. So that data definitely also added to the decrease in performance. If anyone is interested, I recommend looking up, it's not showing up on this screen, but I can show you later. There's a paper we published in Angavanta Chemie in 2015 that sort of chronicled our experience with this field trial, as well as a field trial with a company called Diagnostics for All, which makes paper-based diagnostics, and I think it's an interesting read. To improve our device, we brought in industrial partners. We now have a partnership with Doctari Diagnostics, who's also based in Cambridge, Massachusetts. Doctari has a viral load counter and a CD4 counter based on microfluidic device. We also brought on an industrial partner of Drummond Scientific. Drummond is actually the company that makes those small microhematocrit tubes, so they're the perfect partner to help us to improve our device. Besides those two things I mentioned that we realized were what decreased our performance, we also investigated many other conditions, such as changing the pH and the phase density of those systems, adding deoxygenated agents in order to induce sickling to hopefully improve signal, adding heparin to the system, and sterilizing them for long shelf life. Most importantly, and the data that's shown here on the right, is that we found that glass capillary tubes provided significantly better performance than plastics. And we believe that's because the plasticizer over time leaches out into the polymer solution and changes the parameters of it, including the phase densities. So you can see if this is the diagnostic cutoff using a digital reader for the system, there were no false positives with glass at both 4 and 22 degrees C after being aged for over a month. This is what the new generation device looks like. It is a glass tube. We have separated out the collection device now in order to maintain a solid heparin coating on the system over time, so we can separate the liquid components from the dry components. You add the collection tube once it's been filled with blood into the device. It's tapered so that it won't go through. When you centrifuge the device then, you again observe the dense red cells at the bottom of the tube. Importantly, Drummond has made a tube that has optically clear glass, and so it's even easier to visualize by eye. Through all of these studies, we've been doing digital analysis with these as well, where we take the tubes and we scan them in a simple desktop scanner. But we've also begun to incorporate a reader into the centrifuge itself to be able to do this automatically. Here's the performance of our Generation 3 device that we're currently working on. These results were from samples that were stored for over 2 weeks, and in some cases were sent across the country to mimic shipping conditions. We now have a better sensitivity and specificity than we did in our original device at Harvard, with an N equals roughly 150 patients of 96% and 97%. And importantly, we found good performance with 2 samples of hemoglobin S/O Arab, which we had not tested before. The critical next steps for our device is we have another field trial in Zambia in the first quarter or second quarter of this year. The planning is a little bit up in the air at the moment. We're going to go back to the University Teaching Hospital in Lusaka, Zambia. We're also going to take the device to a more rural area in Chitambo Mission Hospital in Chitambo Village in order to look at other complicating medical conditions and hemoglobinopathies like severe malaria, high hemoglobin F, or severe anemia, which we believe could impact the quality of a density-based device. I'd like to leave and end here with sort of the idea that I think that this system may be better as a platform technology, similar to what the last presenter showed, as compared to some of the dipstick technologies that are going to be presented on next. We have tested and proved the test can work for sickle cell disease, at least in certain conditions, but we've also recently published a paper sort of turning that concept on its head of looking at dense cells, but instead looking at microcytic hypochromic cells for iron deficiency anemia, and developed a test to detect iron deficiency anemia either by eye or, importantly, we used digital analysis and machine learning to actually calculate some of the parameters of a complete blood count. So I believe that this platform could potentially move towards looking at more disease states and also potential clinical manifestations by adding more data to the system. I've already thanked many of these people. There are many others, and I'd also just like to give special thanks to funding agencies, Bill and Melinda Gates Foundation, Mass Gen Hospital and Camtech, the NIH, the Blavatnik Biomedical Accelerator, and the Harvard Global Health Institute, all for their funding. Thank you very much for your attention.